I'm so happy to have you with us, and hopefully more people will be joining. We understand everyone in Sudan, the humanitarian and health sector, are very busy with the emergency response. But we also wanted to have this opportunity to conduct this session with you and to have a discussion together. And so think of this event as a more of a collaborative discussion and space. My name is Asia Kambala and I'm project manager with Internews. We worked on the Rooted in Trust project, and today joining me as well is Ingrid. Ingrid, over to you to introduce yourself.
Hi everyone. I'm not quite sure what you can see, if you can still see my face or just the slides, but whatever. Hi, I'm Ingrid Gerkema. Oh, Asia, go ahead.
No, go ahead.
Okay. Hi everyone, I'm Ingrid. I am an applied anthropologist and a consultant for Internews and Clear Global. I've been helping the team at Internews in Sudan to do the language analysis of this particular research, and very happy to be here with you to help talk through the findings of this study. Back to you, Asia.
Okay. Yeah, thank you so much, Ingrid. So this project or this research falls under the Rooted in Trust project, which is a pandemic information response project focusing on responding to rumors and misinformation about the pandemic and COVID-19 vaccines, as well as other health issues. And it's funded by BHA, USAID. And the reason we picked this topic today, well, Ingrid, maybe we can go to the next slide, please, just to present the researchers and the research focus. So the research team includes YPR Sudan. Unfortunately, the connectivity has prevented them from joining, but the teams from West Darfur, the teams from South Kordofan and from Kassala state took lead in the data collection and in the discussions with the communities on the ground. We want to recognize particularly our team in El Janina of West Darfur, who has been severely affected by the conflict there. A couple of them have been displaced and they are safe now in Adre, Chad, but there are two other team members that we still haven't received updates about and haven't accounted for. So we hope they're safe and their families are safe and that we hear from them soon. So Ingrid, of course, was one of our lead researchers, and Nazik, who is unable to join us today, but was very took lead in part of the research, as well as Waha Ibrahim, who really paved the way in terms of training researchers and people working on the ground in Sudan, as well as preparing with Ingrid the methodology for this research. Now, as noted, Rooted in Trust is a pandemic information response project, and there was a first phase between October 2020 and up to February 2021. And during this time, we noticed that although the vaccines weren't launched yet in Sudan, there was discussion about vaccines, the COVID-19 vaccines, and that they were seen as a form by many. The rumor was that they would be a form of birth control, or and then when the vaccines were launched, there were rumors circulating even amongst the healthcare workers about the impacts of vaccinations on reproductive health, and that they were quite powerful. At the time, the MOH, the Minister of Health, showed the example of the vaccines impact, these types of rumors impacting the vaccine uptake amongst healthcare workers. And we had conducted a first information ecosystem assessment, and one of the recommendations was to look at look at a gender-sensitive approach to health information or public health information, as well as how language and literacy how different literacy levels and different languages spoken by people require various information channels, and that this was there was a clear gap in research in this area for Sudan based on our first IEA. And so based on those recommendations and discussions with health workers, this launched the research that we will introduce today. So these are the key questions that this research explores. How and in what ways does language and literacy mediate access to reliable and correct information on COVID-19 and vaccines? And what role does gender play in COVID-19 risk communication? And how sexual and reproductive health rumors informed acceptance of COVID-19 vaccine, and how it impacted the vaccine uptake. Yeah, so now I will hand over to Ingrid, who will be leading us for most of the discussion in the next slides. So back to you, Ingrid. Thank you. And welcome to all that have joined.
Great. I guess I've just put the slides up for a second just to see who else is on the call. I wasn't able to see your voices, to see your faces without taking the screen away. So given we are with 10 people, I wonder if it would be a good idea to do a quick introduction, and then later on, maybe a quick round of who everyone is on the call, and then we can potentially do a more interactive session. So I won't bore you and go into all the findings straight away, but maybe we can take it step by step, and we could easily discuss it. Maybe that's an idea. Asia, what do you think? Maybe let's make it a little bit more interactive.
Wonderful idea. So people can go around and introduce themselves. So yeah, please feel free. Okay. I see Ayman on my screen. So Ayman, go ahead.
Yeah, hello everyone. I am Ayman Elias, conflict as the analysis advisor for the conflict sensitivity facility, SF. And I'm happy to be here today. Thank you.
Welcome, Ayman. Thank you. Over to you, Jason.
Thank you, Asia. My name is Jason 4-Hour. I am a program officer with USA BHA based in Nairobi and formerly based in Khartoum.
Welcome. Over to you, Marianne.
Hi, everyone. This is Marianne. I'm the projects manager for Andariya. Andariya was one of the partners that worked with Internews on this, the RIT Rooted in Trust 0.1 and then 2.0. And so I'm really, really excited to know about this assessment and, try to see what can we leverage for the future, given everything that's happening right now in Sudan and the mass rampant disinformation and rumors as well, and panic, honestly. So yeah, really excited, Ingrid. So yeah, over to you.
Thank you, Marianne. Over to you, Mustafa. Mustafa, can you hear us?
Mustafa, you're muted.
Well, in
maybe
this case, we'll go to
Rizan.
Yeah, maybe Rizan, you can introduce yourself.
Okay, hi everyone. I am Rizan Tariq, the Information Management Officer for the project. Glad to be.
Thank you, Rizan. Over to you, Ruwaida.
Hello, everybody. Ruwaida Sabil, Federal Minister of Health, Risk Communication Officer. Nice to meet you, and it's a long time from you. I think it's good questions that you said, and good job. Thank you.
Thank you, Ruwaida. Welcome. Over to you, Timothy.
Yeah, hi everyone. I'm Tim. I work at Insecurity Insights. We are doing a lot of work on attacks against healthcare in Sudan, and we're currently going forward, starting working on a report on this topic. So I'm particularly interested in sort of how your research links to the current context. So thank you, everyone.
Thank you, Tim. Welcome. All right, Ingrid, I think you can maybe put it on slideshow mode because the presentation is not on slideshow mode. That would be great.
Okay.
Thanks.
I'll take us away then. Yes. Okay. Well, maybe first of all.
Yeah. Okay, that's better.
Can you see this again?
Perfect.
Asia, can you see the slides? Yeah, okay, great, thank you. So perhaps first of all to say, the data for this study was collected from September to December 2022, so before the conflict. We still felt that it's important to share the data because although, of course, a lot has changed, there are still findings that can be useful. And we have tried to link the data that we have collected in our report in this particular study to the current dynamics. We've done so by putting a two-pager contextual brief at the start to try and explain people how they can interpret this material taken into account current conflict dynamics. I do think it's important, Tim, to note that this data was collected before, and so I don't know if that's still of interest, but why don't we just see, and we'll let you know how it goes. So maybe first a little bit about the methodology. We have, it was a qualitative research project which included a desk review, key informant interviews, focus group discussions, and a more innovative element, I would say, where we were doing comprehension testing of communication material focused on COVID-19 vaccines. That basically entailed us taking pictures of COVID-19 campaigns and showing them to people and asking them, what did they understand? What didn't they understand? What could be improved? And as you can see on the right-hand side, this was done in a range of settings, which I will detail in a bit more. That was undertaken by YPeer, a UN-funded network of youth volunteers. So we collected the data in West Darfur, in Kassala, South Kordofan, and we tried to include people from different vulnerable host communities and refugee and IDP settlements. So we, for example, spoke with refugees from Chad, with refugees from South Sudan, with IDPs in various locations. And we did that really to try and understand what kind of information were they getting and which kind of information weren't they getting when it comes to COVID-19 and vaccines. We, I have to look in the notes. I think we had roughly 23, we did 23 KIIs and 27 focus group discussions with around 240 participants. That was quite a big sample. And we had 50% men, 50% women of different age groups, different education levels and different professions. And in each of these locations, we try to do comprehension testing. So as I mentioned, that involved showing people images of COVID-19 vaccines, both with and without the text underneath them, to try and gauge how they were understood. So these two images were 2 of the 4 images that we tested. They were used by UNICEF and by the Ministry of Health to as part of their COVID-19 vaccine campaigns. And so we printed out these pictures, we went to the people, we showed them, we asked them, what do they mean? It was part of the methodology. The other part included key informant interviews with media workers, with government officials, with healthcare workers, and community leaders. And we did focus group discussions with community members of different refugee and IDP settlements. So that's a little bit about the methodology. If you have questions about that later, we can always do that, but let us go to the more interesting part, the findings. I'll first present to you the findings of the comprehension testing, and then I'll pause and give you the chance to respond and ask questions, and then we'll go on. So, yeah, I think one of the most interesting things when we were testing these images was that already prior to the conflict, traditional media was becoming less available and less trusted because of the military takeover, much more censorship, internet interruptions, news blockades, suspension of newspapers, arrest of critical journalists, but also the more financial impact of the crisis, which had effect on journalists being able to do their work. Of course, the conflict has even more eroded this. And as an effect of journalists and media being less able to do their work because they don't have the finances, or because they're in fact being prevented from doing their work because of more censorship, traditional media have become less available, less trusted. And this is particularly the case in refugee and IDP settlements, where already this kind of media is already not very available, but it has become even less. And so as a result of that, you can see that in these camps, particularly in IDP camps and refugee camps, it's often humanitarians that are doing the majority of communicating, particularly when it came to COVID-19 vaccines. There were many partners that were supporting the government to communicate about the vaccines. And it was quite interesting when we started to analyze COVID-19 information that was available. We saw that there was a lot of written material, a lot of text, very text heavy, and that this kind of material was often not very well understood because there's a high level of illiteracy. Then also most of the material was in classical Arabic, whilst most people either didn't read it or were more understanding of spoken dialects of Arabic. So whilst aid workers were presenting much more and giving information in classical Arabic, that was not the dialect that was preferred by people. And we also saw the use of very fearful images, like the one on the right, where you had very big syringes, which kind of scared people a little bit. Let me detail that a bit more, and then I'll open it up for you. So this is one of the images that we gave to participants, and people interpreted this image totally different. The idea of the image was that it would convey the message that vaccines would save lives. But people really looked at this image and thought it was about the umbrella. And so people were thinking in several sites that actually this umbrella, if you had an umbrella, it could protect you from COVID-19, which they saw as the same sort of strategy as washing hands or wearing masks. And some people misunderstood this to say, well, okay, if you have an umbrella, you can be protected against it. So this is one example of how, if you don't test an image with the target audience, it may be difficult to understood. Of course, there were also people that understood this differently, but without text and just the image like that, it was a bit confusing to people. It was the same for this image, where people told us that they didn't really understand why some of these kids on this photo, on this image, were having a green sort of aura around them. And it wasn't clear what was wrong with these people. It was certainly not understood as a COVID vaccine. and protection. So people were thinking this image was much more about people living with disabilities, or simply just being really confused about what was depicted here. And even if the image had underneath it, vaccines save lives, because many people that these images were distributed to, that saw them, they were illiterate. So even if you had a text underneath that in this case would have said vaccine saves lives, people would not have understood that because they can't read what is written there. So that's something to keep in mind, that people need to be able to understand these images even though they have text that explains it. It needs to be clear. Also, people told us about this image, that there needs to be more variety in clothing because not all people are Muslims, and so they didn't feel like their group was represented in the images. So this image people found really strange and terrifying because it has a big needle and it created a lot of fear. And people also said, actually, the way that this guy is being vaccinated is wrong. Like, you should not have that angle. It should be a 45-degree angle. And people were commenting on the fact that the doctor wasn't wearing protective equipment. And again, also a problem with this image was there's a lot of text and people don't always read that. So it's very unclear, in fact, what was meant by this. That was also the main concern that people had with this particular image, that they said the speech is way too long. And in fact, the image doesn't correspond with the text. This is about vaccination, but that isn't clear if you don't understand it. So there were a bunch of concerns related to that, which was actually quite interesting to hear from people about. They also said the text is too small and too long. So can they shorten it and make it more clear? Yeah, okay, let me pause there. Does anyone have a question or comment or concern at this stage, or should I go on? I see no hands.
I can see Ayman has his hand up and Faisal is unmuted. So go ahead, Ayman. Then we can come back to Faisal.
Okay. For me, it's not a question, it's just a comment, and I think it's about the Arabic text. I think using the word corona instead of COVID-19, this was a good one because it's widely used among the Sudanese. They use the word corona, not like COVID-19 or a translation for it. So using this in the title and also in with other pictures, this was a good translation as equivalent. Yes.
Great, thank you. I think I also see a question from Jason. Why was there a lack of image testing? I think that's really a question to the donor, to the Ministry of Health and to UNICEF. I think in my...
Maybe.
Yeah.
Sorry,
go ahead.
Maybe I can come in here. Go
ahead.
There was, my understanding is there was testing for some of this material, and that there were different target audiences. But Ruwaida is here on the call, and she's from the Risk Communication Directorate. Maybe it's a good idea also to hear. Maybe you have some insights, Ruwaida, on this.
Okay, Asia. Thank you. I think we did the similar job in the product in scientific committee, if you remember, Asia. And we reviewed the messages and the images that produced by the Federal Ministry of Health and UNICEF. And we had a lot of recommendations and we recommended that some recommendation you find in your desk review, but also they not consider the special needs people, like the blind people and illiteracy of people in the rural area. They fall in the same mistake in the first message of COVID-19. I think they didn't correct any things in the first wave, and I think you can recommend this result to the Federal Minister of Health again, because they do a lot of job, but in the final we found mistakes like that. I think it's the same mistake that we found in the product from scientific committee. Over to you.
Thank you. That's really useful. Anyone else for now, or should we continue to the next one?
Yeah, I think one thing that Rueda just highlighted about that this wasn't really tested in a way to that it would be suitable and appropriate for different levels of literacy. Perhaps there are different, communication materials that are intended for different audiences. And I guess this was, I just assume by the amount of text, it might have been intended for a specific audience. But anyhow, it's very interesting in the report. Ingrid provides a lot of detail on how people perceive and see these images and these different flyers, which is super interesting and I think very useful exercise. As you noted, Rueda, we will be sharing it as well with the MOH. Thank you. Back to you, Ingrid.
I only saw Faisal unmuted. I don't know, Faisal, do you want to say something? If not, I'll go ahead. Okay, I think I'll go ahead. And just to highlight a very useful comment Marianne shared, which was, did you ask participants if there were community mobilizers explaining these illustrations when the community was first exposed to them? Yeah, we did ask people. In some cases, participants mentioned that there had been mobilizers who spoke their own local dialect and their local languages. And when they had been involved, it was much better for them. They were able to understand it much better. They were able to ask much more questions. Not in all locations that happened though. So in some areas, the people had actually never seen these posters, but where community mobilizers have been involved, it was often, much better, provided these people spoke the right languages. And I'm gonna continue on that a little bit more. Share screen. Yeah. Okay. So we asked people what languages they spoke at home. This probably won't surprise you, but it wasn't. We first asked people what languages they were speaking, and then Arabic came out. And so initially I was quite surprised because I thought Arabic, why don't people then understand this material? But later on, the team explained to us that it's about dialects and about different types of Arabic that were spoken. So when you read this finding, it's not only classical Arabic. And it was quite interesting. And one of the quotes of the participants in CC camp really brought it home. They said, when it's in classical Arabic, some people don't understand it because we use more one of our dialects than Arabic. And they said it's better if you use that, like the everyday language, than that you use the classical Arabic that they speak in Khartoum. Of course, people also spoke a range of other dialects, languages from home, and particularly when you're dealing with refugee communities, you have a range of different languages. And I think an important point is when we are planning our communication plans and when we're planning our communication campaigns, can we at the start assess which languages are being spoken and preferred and which dialects people prefer? And then that would really increase uptake. I guess another thing that we really looked at was gender sensitive risk communication. So how, in what different ways do men and women access the information about COVID and COVID-19 vaccines, who are more at risk, who are not more at risk, and where do they go to access this information? And it was interesting, and probably doesn't come as a huge surprise to you, but that women and girls more often get information informally through friends, through female relatives, through when they get water, and when they're cooking together at the water well, whilst men more often get information from public spaces, from the community leaders, from the tea houses. And so the type of information that they get is quite different. And age and socioeconomic status plays an important role. Particularly older women are more at risk of not getting information because of low literacy levels and limited access to public spaces in general. And this has all sorts of ramifications for how vulnerable people are to rumors around COVID-19 and vaccines. And there I'm going to kick it over to Asia, who's going to explain us better how that goes.
Thank you so much, Ingrid. So now I'm going to look at the last component of the research. Sorry, I'm just going to go ahead and mute myself. Okay. All right, so we're going to look at the specific issue of reproductive, sexual and reproductive health rumors and how they impact vaccine acceptance. So we wanted to share a little bit from the data. So between January 2022 and March 2023, Internews and its partners collected 5,940 rumors, out of which 360 rumors highlighted the perceived harmful effects of the vaccine on reproductive health. And we wanted to note that of that data, looking at the total overall data collected during this period, COVID-19 treatments and cures accounted for about 15% of the data. So that was the top thematic category, followed by safety and side effects of the COVID-19 vaccine. And then people still saying that, people who started to say that the vaccine is endemic, and it is no longer that harmful and it's like a cold. And then also people who said the vaccine is a hoax the pandemic is a hoax, continuing to deny the existence of the virus. And then sexual and reproductive health rumors accounted for about 6% of the data. That's in both data collected online and offline. However, when you look at the data on sexual and reproductive health, both online and offline, you find that the majority of that data came from face-to-face listening groups held in 10 states, including the entire Darfur region, the two areas, South Kordofan and Blue Nile, and the 3 eastern states, Kassala, and the Red Sea state. So we just wanted to highlight that conversations about the possible effects of the vaccine on reproductive health were happening mostly during listening groups rather through online conversations. If we go to the next slide, just wait for Ingrid to switch. Yeah, this is a visualization, just several visualizations of so sexual and reproductive health rumor data. So we find that the majority of the data is shared by women, and women are also sharing about 44% of the data. So the gap is not very different, but we're going to explore a little bit later in the presentation how gender plays a role in influencing perceptions. And this is a breakdown by states. We found that most of these types of data or rumors are shared in Blue Nile first. That was the top state, and followed by South Kordofan, Central Darfur, West Darfur, and then the remaining states, the lowest number in Kassala, and with the highest in Blue Nile. And here's the breakdown of locations. We found that most of this data was collected, offline data was collected from IDP camps, so 23%, and then the remaining with host communities. We just wanted to show this visualization to get an understanding of where this data was coming from and in what types of settings, and just looking at the gender breakdown. Let's go to the next one, please. The next slide, Ingrid. Here we want to highlight the research showed that how society can have an impact, and societal pressures to be more specific on how people perceive and behave, and how they make decisions on whether to get vaccinated or not get vaccinated. And it was noted, the IEA report notes that men were especially affected by these types of pressures. There was, for example, this quote from one of the respondents. The rumor on infertility, that the vaccine can cause infertility, has negative impact on our mental health. The community has no mercy. If they get to know that you have taken the vaccine, they will say, that's it. You will not have children again, and this judgment is harmful. People think that if you take the vaccine, then you must be a coward and that you are not a man. This man said this, the group of men talked about this in Sisi camp in West Darfur, and were sort of in agreement. And this could come also from the fact that in African societies, childbearing is considered essential and a way of consummating the marriage. But there is little, it's worth noting that there is little research on how childlessness or infertility impacts men in African cultures or society. But it is worth noting that childbearing and having children are considered very important in Sudanese culture and societies, and that they are seen as the children will take care of their parents in their old age. And so it's not surprising at all that these types of rumors would have such a big impact on both genders. But what was really interesting about this component of the research, there is always this assumption that women take that burden, but it was interesting, the burden of childbearing and the fertility. If there are ever fertility challenges, it's usually the women who take that responsibility. So it was very interesting and revealing to see in the research that, in fact, men are very much affected by this, and that there is some stigma in some communities in Sudan around childbearing, and specifically for men. And we can go on to the next slide. where we'd like to highlight a bit more on how rumors continue to have this real life impact on people. There were high number of rumors about how far tying between fertility and vaccines. And this isn't necessarily rumors tying between the pandemic. Anyways, were from the very start, before the launch of the vaccines, people were talking from the very beginning that the pandemic was a way to control populations and a way to reduce global population, or a way to reduce fertility within African or Muslim communities or countries. This was noted from the start of the project. And there were rumors, then these rumors developed more with the launch of the vaccine, tying the vaccine to fertility, and also speaking about looking at it from a gender angle, that the vaccine can impact libido in men, and that large percentage, the majority of the data on sexual and reproductive health focused on around pregnancy, speaking about pregnancy and how the vaccine can affect pregnancy. And as we noted, how these types of rumors are related as well to value, and how men and women are valued within their society, and how not having children, how that is perceived and can impact their societal status. It is worth noting that there is limited communication material addressing and these types of rumors, but we under Rooted in Trust, and also we know that the Ministry of Health had identified this as a key issue when there was a big effort to tackle these rumors and this type of misinformation. Next slide, please. Yeah, and we just wanted to highlight here how people look at how the respondents perceive the different, what are their trusted sources of information. And the study found that men trusted the information that was coming from the Ministry of Health in terms of the sound bites that they would hear when they would make phone calls, the health messages, the messages that were being broadcasted on the radio and shown on TV. And this was unanimous across the 3 states of West Darfur, South Kordofan, and Kassala. And it was also noted that in comparison, women were more likely to trust information from their friends and family members. Women were more trustful of people within their close pool or close community. And this also can be related to how these different genders are socialized, in terms of men trusting more often trusting their own expertise and the expertise of others, whereas women are more socialized to prioritize relationships and opinions of those they know and those within their circle of friends or trust. But of course, these are, we do recognize that these are generalizations, and there are individual preferences and perceptions, and that this doesn't apply to all study respondents, but it's something that we noticed for some, and it was worth, we thought it was worth sharing with you here and adding to the research. We can go to the next slide. We also noticed in Waunur, particularly in Kassala state, that even when the information was, the same information was provided to men women that there were differing perceptions. For example, we grabbed these two perceptions here, showing this. Access to information is fast and accurate, said a man from Kassala. It is communicated through telephone under the directive of the MOH. Telecommunication companies send text messages and audio recordings before each phone call or while waiting during a call. A woman in Kassala says, I need to be educated to take the vaccine. I didn't take it because I didn't have enough information. So even if both, we notice both groups are hearing the same messages pass through these phone calls, the way they perceive it and the way that they process information could be different, which we think could be an indicator that there needs to be more considerations and risk communication to gender and how different groups may communicate. But just like people listen to rumors and they are very influential on how people make their decisions and perceive the disease, but we also notice that people are able to process this information and when provided with logical information, they're able to reason and refute these rumors. So people are able to use their own verification skills and processes to dissect these rumors. For example, this woman from West Darfur, Al-Farouk, says, at first I refused to take the vaccine. I was afraid that I may not be able to bear children, but then I saw that my neighbor gave birth after her second dose. I was then convinced to take the vaccine. And there are other examples of people sharing, both men and women, their reasoning process. And it often involves looking at their peers and who have taken the vaccine or have gone through that experience, and they were okay health-wise, and it didn't impact their ability to have children. So I think it's very important to highlight this and to have more of these examples, people that are considered trusted voices within their communities who have taken a specific health measure or taken the vaccination, to share also and to take part in community mobilization and sharing information. I think, Ingrid, you need to go to the next slide. Yeah, that's great. So that's it from me, and I'm going to hand it over to Ingrid to talk a bit about the recommendations coming out from this research. If you have any questions, if there are any points, we're happy to hear from you, and feel free to unmute. Over to you, Ingrid.
Yeah, thank you so much, Asia. I've just taken the presentation off for a second to give you a chance to respond to what Asia said, and then I will come back later with the recommendations. But go ahead. I see in the chat. No, that was Asia. Does anyone have a question to Asia? Do you want to react? Go ahead, unmute yourself and take the floor away.
I think we can go on to the recommendations. We have a couple of slides, and then we can open it up for discussion. Back to you, Ingrid.
Good. Let me then share it again. Okay. Yeah. Yeah, so I think, so first of all, we asked participants part of the research what they think that we should do, as in we, the humanitarian space, humanitarian agencies, but also government agencies, NGOs, local organizations. So first of all, and we think that some of these recommendations are still really important to keep in mind, particularly when we think about communication, risk communication in the current conflict. So one, I guess the most important one was use images in spoken communication. Not only, don't just focus on written communication because many people can't understand it. And when you do, please use simple colloquial Arabic. Of course, this is not the right way to communicate for each and every single audience. So I guess I would add, first find out who you want to target, what level of literacy they have, what language they prefer, what communication formats they prefer in the first place. But if you are working in more rural areas or maybe with more vulnerable groups of the population with high illiteracy rates, think about using images, spoken communication, test the images, of course, make sure that people understand them with and without the text. Use pictures that can represent information so that people with disabilities can also understand it. Make sure that you understand the communication platforms that people already use, and don't just think about social media or radio, but also think on how you can leverage some of those offline platforms that people use, like at the market, in tea houses, coffee ceremonies, tea ceremonies, all these kind of groups are available. Of course, with the conflict, I'm sure there are many different challenges related to that. But try and map and find out what is available. People also said that going through community-based organizations is a really good idea. And that health centers in the neighborhood level could be important partners as well. And yeah, I think when it comes specifically to vaccines, it's really important to not only say that it's important to get vaccinated, but also to communicate about the availability of the vaccines. In some of the groups that we spoke to, people said, well, I have heard now that I should take the vaccine, but it's not available. So it's also good to communicate when are they available again, when not, what are the barriers, and if you can't deliver it, why is that? And try to avoid using scary images of big needles. There is already a lot of fear and misinformation about the vaccine, so that really doesn't help. So I think these were direct recommendations of people that we spoke to, and we then try to explain a little bit better how we as humanitarians can use that. So I think the most important thing, which I'm probably telling you and preaching to the converted, but effective risk communication, is it whether or not it's about COVID-19 or vaccines, or currently where in the conflict can you access services, what is safe, what is not safe. It really needs a thoughtful approach that considers the language and literacy levels and preferences of the audience. It also needs to have very practical information that people can act upon. So if you say that the vaccine is available and that it's important, also at the same time say, where can you get it? What are some of the considerations for the follow-up vaccine? Do people get a health certificate or not? It's easier to act on information that has actionable elements of it. And I think that can also be applied again to the conflict. Like if there are certain services, how can people access them? How can they access them safely? How can they make a complaint about it when they can't access them safely? Like it's very important element of it. I think it's also really important, the research showed, that communicators should use a range of channels and really try to understand before you set up those channels which platforms and channels women and men actually access, and being sensitive to the gender element in it. Try and involve both gender in the planning and the design process, and try to help people that have certain vulnerabilities, like people with disabilities, for example. Try and think about them too when you're planning your strategies or communication plans, and make sure that they can access them. And then I think 2 more specific findings related to COVID-19 and vaccines. It's important to test comprehension, but also make it's important to respond to concerns that have the effect that can limit the uptake of these vaccines. For example, on fertility, make sure that you're able to track the rumors, that you can quickly respond to them, and that is important throughout. And I think because it's about such sensitive cultural issues as well, it's also really important to take time to encourage people to ask questions, to share experiences, to share fear, to encourage dialogue, and to do that with people that are locally trusted, like local health workers or community-based organizations. Give people the opportunity to ask questions about such sensitive matters. So I think with that, in very rapid succession, we have I have finished sharing what I wanted to share with you, and I'm really curious on your take and to learn what you guys think should be done, and also interested, Timothy, in hearing more about your research and how you think we should take this further with the current conflict in mind. Over to you guys.
Can I come?
Yes, go right ahead.
Okay, I want to ask you if you ask the participant about if any intervention or correction related to the rumor regarding to the reproductive health or not from the health authority, and if they looking for the right information or not, or just hear the rumor and just keep it. If they seek to solution or seek for a right information or not, because that reflected the intention of people to obtain the right information. Because if you did a lot of good recommendation for the health authority, but if the people they have an intention to change their behavior, I think the work is not success. I don't know if you measure the feeling or the intention of people regarding to this rumor or not. Over to you.
Thank you. Asia, do you want to come in?
Yeah, maybe. Ruwaida, could you just clarify a little bit more? It wasn't, maybe
Okay.
there were 2 questions. Go ahead.
Okay. Question number 1, if you ask the participant when they hear about the rumor, how they deal with the rumor, if they keep it and refuse to take a vaccine, or seek for more right information, or to change their behavior. This is question number 1. Question number 2, if they seek for right information, if they have an intention to change their behavior from refusal to take a vaccine or not. I think 2 questions can help the health authority to make a better intervention in the area. If you got
let
me
me take
asking.
that. Yeah, I got it totally, and that's a really good question. Well, we asked the woman what happened. So some of them said that they heard a rumor and as a result, they didn't take the vaccine because they were afraid that they would get infertile from it and that their husband wouldn't allow it. So, but there were other women that actually had seen friends being vaccinated, pregnant women that were vaccinated. They saw midwives, they saw people that they respected in the community get vaccinated. And then they changed their mind. Basically, they said, okay, well, now we have seen with our own eyes that this person was pregnant. She got vaccinated and nothing happened. She didn't lose her child. So in that sense, it changed the behavior when people were able to see it, when trusted friends or family were able to verify, and then they could go back to their husbands and say, look, but my friend so-and-so was vaccinated and there was no problem. So I think working with people, role models, examples that have gone through it and visually showing people that it hadn't had an impact was really important and could really be useful. I don't know if I answered your question.
Yes,
Asya,
yes,
do
you
you want to
answered.
add?
Yeah,
Yes,
because
sure.
just
Go ahead, Ruwaida.
information, yeah, we don't just share the information to the people. We don't know how they perceive the information in a right way or in a wrong way. They understand the message or not. We don't just focus on the information that we deliver to the people. We want to work in other sides, like measure their intention, make assessment for the environment, the influencer in the area. All these factors can affect the behavior change or the uptake of the vaccine. I think when you consider these factors, I think it will be better.
I think it's really good recommendation as well. We will include it to make sure that you always measure the impact of it and document lessons learned. Good point.
Okay.
Mariam?
Yeah. Can I just come in, Ingrid?
Yeah,
I just
go
want
ahead.
to clarify because she had Ruwaida had the two-part question. So Ruwaida, I just wanted to share that you asked if we were able to measure whether people had changed their perception about vaccinations and took and decided whether to take or not take the vaccine. We noticed through our work, we weren't only conducting rumor tracking via social media and face-to-face conversations, but this regular, listening process, we're able to identify what the information gaps were, what were the information needs, and which areas we needed to respond to with our partners. So there are a series of events that took place and different activities. Like our partner Andariya was leading the digital production online and as well supporting social media listening. And YPR, Sudan, and as well as CASE, Khatim Adlan Enlightenment Center were involved in responding directly, either during listening groups or via events like street theater, music. And there were times where CASE succeeded in having because in one event they had in South Kordofan, the community asked where can we get vaccinated, and there weren't vaccination centers very close to them, and so this was shared with the MOH, and for the next event they had, they were able to get the MOH to send mobile clinics, and this strategy was used in both South Kordofan and Blue Nile. And that was, there was a notable change in perception. And there's always going to be a group of people, a number of people that are not convinced to take the vaccine. And this could be the impact of previous vaccination programs, the impact of colonial legacy and stories that are shared about about how medications have been given to control populations in other areas. And even if that didn't necessarily happen in Sudan, these types of messages are passed. And it is really worth noting that through our data, we were able to identify some serious concerns the communities have with medicines, and that there was still a big reliance on herbal remedies and natural treatments, and a mistrust of pharmaceuticals. And this was noted even amongst, not only amongst lower literacy levels, but even amongst people who had gone to university or had finished high school. So there are a number of layer of things and reasons and challenges. But yeah, just wanted to share with you, there were cases where people did get vaccinated, and it was very useful to have this process of listening first, and then using contextualized and culturally relevant formats, as Ingrid noted, and also respecting people's languages and preferred communication channels. Over to you, Marianne, to ask your question.
Okay, so I think it's a question, and I have a comment. I think it's very important to contextualize that maybe perhaps some of what we would think is like poor response from the WHO in terms of like image testing and, you know, making sure that things were understandable, is I think we need to contextualize that when the pandemic hit, I think there was a sense of panic in the WHO, which is understandable, and they just kind of wanted to get information as fast as possible and get it out as fast as possible. And I think that's still a conversation that needs to be carried forward, because when any crisis happens, I think the first thing is you want to get to beneficiaries, and sometimes you don't take the necessary time to do it in the best way. I hope that that's making sense. I think that's just one thing, maybe to not come down too hard on the WHO. And I know that you're not, but as someone who's listening to it, yeah, exactly. Rush happens every time there's a crisis, and, you know, making sure that, and that's why I think this is what I'm leading up to, that I think having these kind of assessments and ground zero and baseline like studies and numbers to go back to are really good to use and utilize when a crisis happens. Okay, what do we already know about the system? And that's why I think information ecosystem assessments are super, super important and very, very useful. And I know you said that this was, you know, conducted in a very different context, but, you know, the findings and the behaviors are still mostly the same, of course, largely affected by displacement, et cetera, et cetera. So that's the first point. And the second thing I wanted to ask is, if I understand correctly, there is a sense of trying to understand the different impact on genders. It's trying to be a gender sensitive study, not trying to be, but it's supposed to be, you know, assess the gendered impact of COVID. I wonder why maybe the sample was evenly split for the methodology. I don't know, would it have been maybe a little bit more insightful to have maybe a 60-40 ratio of women to men, maybe just to really dwell on the impacts of the COVID communication, because we know that it's women and girls who are more affected. You know, that's all from me. Great work, by the way.
Thank you, really interesting. Good point. I think it's something that happens at every single crisis, and it's really interesting to think how we can change that. And I'm really interested as well in hearing from Timothy after this, how we can take some of these findings to, you know, the current situation and what we can do with that. And I think it is definitely not about one donor or one organization bashing. I've seen this in many countries every time it happens again, every pandemic, every crisis. But it also baffles my mind, because all of us were working in Sudan. There are people that have expertise on Sudan that could be consulted. So we know a crisis is going to happen. Why do we make the same mistakes? It's fascinating, interesting, but I'm happy we've been able to add it a little bit to the evidence to the to the sector. And I think your point about the 40-60% sampling, honestly, I think that also had to do with the complexity of the research. We were in conflict areas. We could have done a more complex sample, but we're also working with YPeer. It was difficult to communicate. It was a big challenge. I think it would be really interesting to commission a next study, really drilling in even more on user-centered recommendations and really working out with women, and I would perhaps do even 100% female sample for that, is to understand where do women go, which informal communication channels do they use, and how does that impact, how actually do rumors spread? To tracing a rumor from the beginning to the end would be super fascinating. So just to say, methodologically, I think there could be 1,000 different changes, and we could do 1,000 different things still. Thank you for your point. Timothy, over to you.
Yeah, sure. Yeah, thank you so much for your presentation and the findings. I'll just try and say a bit about what you're saying you'd be interested in. So I can't really share that much in terms of findings yet, because we're at a very early stage. But what we will be doing is, I can actually share in the group chat now, because what we do is we document attacks on healthcare in conflict across the world, and we do an annual report. Normally that comes out in sort of June time, but this year we are, or particularly with what's happening in Sudan, we're very keen to do a report which focuses specifically on Sudan, and will hopefully come out in the next month or so. But we've obviously been documenting attacks like on an ongoing basis on healthcare in Sudan, and it obviously at very, very high levels. So I'm very glad to have been able to see your findings today, and I think a lot of what you have been talking about will be relevant for us when we are drafting our policy recommendations. So that's sort of the context. Yeah, I'm sorry I can't share much more on the findings yet, but if you're interested in when we actually bring it out, I'd be happy to share it with you.
I think it's absolutely fascinating. Thank you. It's also really interesting to think about how to take that forward and how you communicate this to a wider audience, and how people in Sudan themselves can also, how do you make practical recommendations currently now about safety and conflict dynamics? Absolutely fascinating. Thank you for sharing that. Ayman. Oh, go ahead.
No, I was just going to say for sure that, yeah, I think that's really interesting, because so much of the conversation will focus on like international humanitarian law and talking about these principles, but I was having some really interesting conversations about people in Syria who were really, really keen that we push agenda of actually protecting health facilities, like with practical measures. I mean, that's just another sort of thought, but it's something that we've been talking about. So yeah, thank you.
Excellent. And Ayman, I also see you have put something in the chat. Would you like to share it?
Yeah, I was just trying to mention about, because you already mentioned about the communication, the effective communication tools, and that there are some people who cannot understand the Fusha, the Arabic standard. So I think also the drama can be a good tool for this, as they can use the daily language and also the different local dialects. They can use it to deliver the message, and this not necessarily to be through the official TV or radio. There are other local radio, TVs in all the Sudanese states, and maybe in addition to this, also there are other platforms, maybe like including religious one like the mosque or churches. They can be like during the Friday service, the speech, something like that. Thank you.
That's really interesting because women who were part of the study actually did bring up drama as one of the preferred ways of discussing it. So yeah, I think that's a really nice idea. I don't know, anyone else with a comment, a thought?
I was wondering, sorry, go ahead.
I want to add something regarding
ahead.
to communication tools. I think also the word of mouth is very effective from trust people in the area. I think if they trained well how to deliver the messages, I think they will make a change in the knowledge of the people in this area. If they consider the influencer also in the area, I think, I mean, not official channel, unofficial channel. I think Al-Hakama in Darfur, people like that. I don't know if you found examples in the area. Some people influence to deliver the information to people. I don't know. Over to you.
Ingrid, happy to take that one.
Go ahead.
As Ingrid had noted, Rueda, the research for this is a smaller type of study, but definitely especially women noted that they that they relied on their circle of trust and people around them, and that it was a very important element that the information came from someone that they trusted. And also people noted that having several sources of information to sort of verify information that they were getting about the vaccines or the pandemic or other health issues was also important to them for trust. So you're absolutely right that there are certain individuals that are very influential, like Al-Hakamat and others in communities. But what was noticeable, people were also influenced by their peers, as we had noted that in the case of women, others in the community, or men that had taken the vaccine and were able to have children. So that was very important to see these examples, and as Ingrid highlighted, that it's really important to see these various examples and to use different communication and information channels, because my preferred information channel, for example, may not be yours. My preferred language might not be your preferred language. So acknowledging this diversity, and not only in language, but also in media preferences and communication channels and formats, like face-to-face communication, like street theater. Street theater was one of the communication channels and formats that really stood out, and people liked the visual communication. So I think that is something that really came out from this research. And the previous study that we had conducted, the first information ecosystem assessment that was conducted in and released in March 2021, also showed about 70% of community members that participated in that research said that the community involvement and community mobilization that Marianne highlighted in the beginning was really important as well for trust and really for verification of information that they were getting. I hope that answers your question. Over to you, Ingrid.
I guess the last question was one in the chat from Jason. If we have time, he asks if there was any disaggregation in communication about various types of vaccines. So were there any messages around the Chinese and Russian vaccines and Western manufactured vaccines? I can't remember seeing this in the data. So I'm going to open that up to the floor. In your experience, I don't think that we necessarily collected it, but Asia, I think you have with your rumor tracker.
Yeah, I think I noted it briefly in the chat to Jason. That we noticed in the communication, public health communication that was being shared, that it was not necessarily focusing or spotlighting a vaccine, but trying to treat the vaccines as all effective and safe, and that vaccines were equal, that there wasn't one vaccine that was better. It wasn't the Russian or Chinese or Western vaccine that was better, and that they were all equal. But of course, there were specific challenges and reservations and fears people had about, for example, the Johnson & Johnson vaccine or any of the other, or AstraZeneca. And so these were things that the way I noticed the public health information that was communicated on key issues like vaccines causing stroke or vaccines not being safe. These were addressed in a way, in a language that didn't single out one vaccine. From my experience and review of the public health information, of course, we saw specific issues, and the way we dealt with it was, and it came up during listening groups. Our partners heard them as well, and the way that they were addressed was to talk about the specific issue and to highlight, what are the potential side effects, and are there adverse events that are related to these vaccines, and looking at it, how prevalent are they? Of course, any medication, any pharmaceutical has some side effect, and it doesn't work for everyone, but that there's always a minimum level of risk or a very adverse event. And this is something that it's important to be very honest about this and to share and to spend the time to have these discussions, and definitely these issues were addressed during listening groups, and also in our in the different digital content our partners produced, various communication formats, whether it was for radio or street murals. These different issues were addressed. Ruwaida, would you like to come in and talk about how MOH may have communicated about certain rumors or reservations people had of specific vaccines? If you're still there.
No, I think MOH deal with all vaccine at the same level. They not prefer vaccine to other. I think the rumor about the vaccines from outside that affects the uptake of the certain vaccine, but MOH not considering these issues, the differences between vaccine, if I get your point, Asia.
No, that's it. Yeah. Thank you so much, Ruwaida. Back to you, Ingrid.
I think we are at time now, and I wanted to thank all of you for participating. If you have any questions, you have our email addresses, I guess, on the invite. And thank you for attending. Asia, over to you.
Thank you so much, Ingrid. We really appreciate all your effort and contributions to this research, and we'll be sharing the full report soon. We're going to upload it to the website and share the link with you. There's an Arabic and English version, and the way that would be really great to share it with other MOH colleagues, and let us know if there are alternative ways of sharing the research, if we should put it on Telegram or somewhere else, because we know that connectivity is a key challenge right now for people in Sudan. And we want to really appreciate and acknowledge all those that were involved in this research, including my own team, Mustafa, Rizan, Nazik, Ingrid, Hassan Birkia, Waha, who have all contributed immensely to this research, and of course to the YPR teams in South Kordofan and in Kassala and West Darfur, and we hope that everyone is safe and stays safe. And we probably will be repeating a smaller presentation of this research to the health cluster. And as Ingrid noted, you can reach out to us. You have my email, and I can connect you to Ingrid for any questions, or if you'd like to connect with her directly. Yeah, thank you so much for everyone that attended today. We really appreciate it. We know everyone's really busy, and so thank you for taking the time, and take care and be safe. Shukran jazilan, and big thank you to Christoph for always being an incredible co-host. Very quiet one, but an amazing one. Thank you very much. All right, be well everyone. Ma'a salama. Bye bye.
Bye everyone. Have a good day.
Thank you.
Thank you. Bye.